Welcome to another EMCT podcast on the topic of onboarding in emergency medicine. We're recording this on November 1st, 2023, and our guest today needs no introduction in the emergency medicine community. It's the one and only Dr. Rick Bukata. Dr. Bukata has been a virtual mentor to emergency physicians and advanced practice providers over many years, long before the word virtual was even part of our lexicon. Let's join that discussion now on the topic of onboarding education and more. Welcome to another podcast on the topic of onboarding in emergency medicine. We have a special guest, in fact, I'll say very special guest today, Dr. Rick Bukata. I appreciate you coming to talk with us on the topic of onboarding, Rick. And despite the fact it says Dan Bukata on your screen there, we know that that's really you.
Yes, actually, I'm in Arizona where my son Dan lives with our two grandchildren. So I'm here have to come every Halloween and go around the streets in our little golf cart as they gather. The amount of candy they gathered was unbelievable. And some of them actually gave these $1.25 candy bars. I don't get it. Nobody gives apples anymore,
Well, they're very generous there. I think I'm gonna have.
They are.
I have to make a trip down there.
And we're also beginning the great time to be in Arizona.
Oh yeah.
The high today was 84. It's just they earn it though. I mean, they're here year round, and during the summer the month of October set a record in terms of the average high for October, so it's getting to be a challenge.
Yeah.
But my grandkids have been born and raised here. They don't know any better. They don't know that it's nice other places,
Well,
they think it's 110's okay, no problem.
It's getting a little vacant up here in Minnesota as all the snowbirds are heading down there.
They're all down here. You see these Southwest flights full of. Yeah. These Southwest flights, I remember, they're all full of old people coming down here,
Yeah, well, I visit my brothers that spend a little time down there. I'll go down for a couple of weeks and get a break at some point this winter.
Yeah, I think I would probably do the same if I lived in Minnesota.
Yeah, we've got snow on the ground already for
oh really?
Yeah, we've had some already. So, and the ice is just starting to crest over the lakes. So
yeah, our last rain here was September 12th.
Wow. So, well, on the topic of onboarding, there's no one who's more legendary than you, and in education and all. That's well, there's truth to that. But I really want to start with me personally and my training in emergency medicine. I finished in 1993, and emergency medicine abstracts was up and rolling and was really instrumental in helping a lot of us stay current in the literature. When did you and Jerry start doing that? What year was that?
Well, I started in 1977.
Oh, wow.
The first issue was September of 1977, and we didn't start making recordings until somewhere in the 80s, probably, when I thought I would take advantage of this new technology called a cassette, and I tried it myself, and it was a disaster. And somebody said, "Hey, there's this guy over at UCLA. You ought to talk to him." And Jerry was, we hit it off, and that we did it for, I don't know, 20 some years, I'm sure, at least.
Yeah.
We probably stopped doing it together probably 6 or 7 years ago.
Okay.
And Mel Herbert and his group, MRAP, took it over and ran with the ball. So they're doing their version of emergency medical abstracts with 20 or plus papers a month.
Yeah.
I think honestly, although it's kind of painful medicine, unfortunately, emergency medicine is a horizontal specialty. So the best papers are in the orthopedic journals that relate to us, and the pediatric journals have got the pediatric fever stuff and all that. Yeah, and we have some, but it's really you. And the weirdest thing is the biggest articles in emergency medicine are in New England Journal. I mean, it's you want to get your papers into the New England Journal. Of course, none of the ER docs know about the paper that you put in JAMA or New England Journal, because they're getting the annals, and probably not too much more. So I think that it's one thing if you're an orthopedist, you could subscribe to the 5 orthopedic journals or something like that, but you
Yeah.
cannot do that in emergency medicine. And I don't know of an alternative, honestly. So you just have to do it. It's painful medicine, but you have to do it.
So what was your training initially in? What did you do your residency in?
Emergency medicine.
You did? In what
Yeah,
year was
absolutely. I got out in 1975 for good
that? Okay.
behavior. I was at the University of Southern California, USC, which is a huge hospital, and they were seeing, oh, they were at the time they were probably in the top 5 in the country in terms of their volume. They had a separate women's hospital, a separate children's hospital on the campus, and then they had the general hospital. So
Mhm.
we would rotate through all of them. Plus, we're at the general hospital, so we had a community hospital rotation just to get us used to seeing what a normal hospital would be like, because the general is not a normal hospital.
So you
But
recognize the need for reviewing all this literature pretty early on and then sharing it with others.
yeah, I was out of my residency by about I got out at 75, so this thing started in 77. So I got the bug a couple years after I got out. I never started anything on my own. I was always an employee of the bowling alley where I worked, or the delivering the newspapers where I worked. I never had my own kind of endeavor. And I'm not quite sure what prompted me, although I think I kind of got a little. I wanted to do a little bit more because I was at a community hospital, and I was going to be there for the rest of my life, kind of thing. There's no career ladder at a community hospital. You are a pit doc kind of thing.
Yeah.
And we were actually our hospital, Valley Presbyterian Hospital, was the first hospital in the country that I believe had 5 ER trained doctors start out there. We got the ER contract, and we were the first doctors in the ER there. And I think that we were the first ER that had all residency trained docs.
Mm-hmm. Wow, very cool. Very cool. So then you went on to have these vacation trips or
Oh, no, no, no,
CME.
no, no. These are serious courses that just
Yes,
happen to be in Maui.
that's
You know,
right.
we
That's
we have
right.
a very scientific way of determining where there's certain needs in the
Ah,
country
yes.
for
Ah, yes.
continuing education. It's highly scientific. So we're going to go to Key West at the end, right at the Sunday after Thanksgiving, the busiest
Nice.
travel day of the year. That's when we're
Ah.
going. And we're going to other, isolated places that need some education, like Vail.
Yeah, 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 yeah.
So
Well, those
somebody's
are
got to
necessary.
somebody's got to do it.
That's right. That's right.
Camping out these areas
Well,
of
I've been to
of
many of
need.
myself over the years. Yeah, those are great educational times and a nice time to get away and decompress.
The
So
idea is to try to do a serious course, which was literature focused, with a great faculty in a great place at a great
yeah,
time of year. If you got all 4 of those things, that was the goal.
yeah,
I think that I think we were pretty successful. I think we had a pretty unique faculty, and our point of view with regards to having a topic and looking at the literature on that topic was different than here's how we do it at our hospital, which was frequently the model
Now,
at
was
the
your
time.
was your target audience emergency medicine trained and boarded physicians right off the bat?
Yeah.
Yeah.
Hmm. Yeah.
And you've had a number of other physicians working rurally and all attend
Oh,
these,
yeah.
I'm sure, as well.
Yeah, absolutely. And in fact, we have not only did we have physicians at that course, we had PAs and NPs. At that time, I think PAs were the people who worked in the emergency departments, and the and majority of people who were non-physicians were PAs. And gradually, the ratio has kind of changed because NPs have become integral parts of the emergency department, and they've gotten a certain amount of appeal in the 26 states that have autonomous practice authority.
Mm-hmm. Yeah. Well, and I've talked to AE and P. Their percentage, not only have the actual numbers of NPs gone up dramatically. I think it's at 360,000 now. It was less than 90,000, I think, in
Yes.
2010, something like that. But it used to be that only about 3% did acute care or emergency medicine. And acute care now has a broader category. It's hard to say how many of acute care are doing emergency medicine, but of acute care, it's upwards of around 10% now.
Yes, I believe
So,
that's
so
the number I was going to give you.
yeah,
Uh,
percentage and raw numbers are markedly increased. So
and there are more NPs in the country than PAs.
yes.
By probably 100,000.
Yeah, quite a few. So when did you start recognizing that you needed to have a separate program for your PAs and NPs, or start the boot camp?
About 10 years ago, it's kind of like I get most of my ideas in the shower. And one day it was kind of like um, there is no training program for PAs and MPs, and that they just oftentimes get just dropped in the emergency department. They were getting more and more popular. In fact, at USC, where I was a resident, we had a residency in emergency medicine for PAs, not NPs, just PAs, and they would come through, but they were very procedurally oriented. It was the suturing and the reductions and the casting, and they could put on a cast better than just about anybody because that's what they did. But and then they were seeing the very minor cases, but they were really focused on procedures. But then they kind of started evolving. But 10 years ago, I thought, nobody was really doing this. And since I thought, why don't we just kind of try to, in a really concentrated program it, and it is concentrated, to give them content that related to probably, I thought, honestly, about 90% of the stuff that walks in the door, we covered in almost 4 days.
Mm-hmm.
I felt, and that I also felt, because we did a manual that they could take home, and then I did tell them that this is a boot camp. This is not necessarily going to be fun, but this basically will give you a new appreciation and a new joy in what you do when you leave here, and less fear, because there was a lot of people who were recently out of their residencies who are being asked to do stuff in the ER that they just didn't feel comfortable about, but they also didn't feel comfortable telling people they felt uncomfortable
Right.
about it. The people who go generally are really
Motivated.
motivated learners.
Yeah.
And they appreciate what you do. I mean, you get a good feeling about it when you're done. One of the things I was very discouraged about when I started this thing is to see the variability in onboarding processes. Onboarding? Yeah. What's onboarding? Some people have a very thorough onboarding process, which, you have certain milestones that you have to reach to be able to, move to the next one and accomplish. And others were woefully inadequate because it was just, here's somebody who can see patients, you go start, and let me know if you have any issues. And then there was this situation where you see these patients, and I don't really want to hear if you have any issues. These are your patients.
Right.
And there was many stories about PAs and NPs, particularly those, recently out of school, where the doctors really didn't want to talk to them. They were, you got, there was, and I couldn't understand that, but um, I'm not sure what it was. I don't know why anybody would do that, but anyway, either
Yeah,
they were too busy or they were not interested, or but the doctors are responsible for every soul in the department,
right,
whether they like it or not. And
right,
even if you are have the capacity to be an independent provider, it doesn't matter. The medical director is responsible for all the medical care that goes on there, and it's like you're it whether you like it or not.
right.
So if that patient goes out and the PA said that, well, the doctor really wasn't particularly interested in talking to me, sign the check.
Yeah, yeah, yeah. No, I know, and there have been plenty of cases like that, and I know of environments in talking with PAs and NPs, and I know from working in various environments that there is that standoffishness. Sometimes there are physicians in emergency medicine that graduate from a program, hadn't worked with PAs or NPs, and they don't want to hear about it. If I didn't see the patient, I don't want to hear about it.
Hmm.
Talk to somebody else, and the PA or
Hmm.
NP will be, wondering, well, who am I going to talk to? And now you've got a different standard of care in a large volume facility where you have some seen by emergency physician and some not. And really, every patient should have a physician assigned to them as well as the PA or NP. And I know in a lot of places on the board and on the track board, it's either a PA or NP, and there's no physician assigned. And that I think is, ACEP is saying now and made it much more clearly, and it always has always advocated for that patients should have or be assigned to a physician, and those PAs and NPs should have some kind of supervision on all of their cases, in those.
That's not necessarily the popular view, but I
Exactly.
but I agree with you 100%. I think this idea of these are minor cases, these are yours, and I'll take the rest is just fundamentally wrong. I think the PAs and NPs should be able to see anybody in the department in collaboration with you,
Right.
and so that we're working together on this case. You can start. I'm over here. You start on that person, even though they're in pulmonary edema. You start on them, kind of thing, and you'll be able to see everybody, and over time, you'll be good at all this stuff. You can't have a career seeing the minor cases for 35 years. You can't do that.
Right.
So let's see everybody together. And in some ways, that is thought to devalue PAs and MPs,
Hmm.
particularly the ones who are out there a long time, who feel really comfortable seeing patients. Because I believe, honestly, that if you've been in an ER long enough, it's you got it. I mean, that's how it was. You don't you don't necessarily need a residency. I mean, if you're in a place where you're intubating and you're taking care of these, then it's kind of like, and they don't learn to intubate in PA school. That doesn't happen.
Right.
Certainly not in NP school. So the idea is that is all learned after the fact. Well, whether they learn it, well, they generally learn it on the job, which is not
Right.
exactly the ideal place to learn. But I think that's what happens. Um,
Well, we've had PAs and NPs that have worked with us for many years, and some have essentially done a 10-year, 12-year
mhm,
residency
yes. Mhm.
because they've really worked with us across, the entire department and been in the trauma bay, and particularly those that work at night have been, tapped on to take care of some sick people when you've got multiple sick patients at once. And even if you get in the trauma bay for a while and they're running the rest of the department, and there's a doc and a PA for that couple of hours of overnight in volumes, greater than 50,000, you're going to get you're going to get PAs and NPs that have had to step up, and you're going to want them to be able to take care of those
Absolutely.
and
Absolutely.
empathize. So we indulge their interests for them to be able to do that, and there needs to be some kind of proper training and onboarding for that so they're prepared for it. But you want them to feel comfortable, and as well as being competent in what they're doing in the emergency department.
Yeah, I think there's kind of 2 ways to look at it. The idea, which we seem to hold together, is that we work collaboratively in the department. All the patients are honestly the responsibility of the emergency physician. That whether they like it or not, they are responsible for everybody. So let's see everybody together, you know?
Yeah.
And some people say, well, that makes me an expensive scribe. Well, not necessarily. You're doing a lot more than scribing. You're doing the initial assessment. You're doing the ordering the things that you think are medically appropriate. There's only two people allowed to order in the ER, the doctor and the PA or NP. That's it.
Mhm.
So you can help us out. You can put some orders in. I'll do this. You can do that. It's kind of like working together. Some people think uh, I think that could be looked at. Well, you're going to see every patient, and the answer is yes. I'm going to see every patient. Will I skip a few? Maybe, but I think that honestly, when you go to ER, you're going to be charged concierge level prices. I looked at a study where they looked at patients who went to an urgent care center, and with the same patients, they would be charged if they went to an ER, and it was $160 versus $1,600. So you're going to get charged concierge level prices. You're going to be waiting out there, and you're not necessarily going to get, but I think that you have certain expectations. Ideally, I like to see a doctor. Now that will be viewed by some people as, oh, gee, what are you talking about? You're going to piss off the entire PANP world. But what would you like for your family? You know?
Yeah.
Now, I'm not saying that you can sew up somebody better than they can. I'm not saying that at all. I mean,
Mhm.
that's a, motor skill. You get that over time and you get to learn what's underneath the skin and those kinds of things. But I do think it would be great, ideally, even if it's just a matter of you sticking your head in the door and saying, "Hi, I'm Dr. So and so. I'm working with, you know, uh, my friend, the PA here, and yeah, he's checked it out. It looks fine. The PA does a history, physical signs them out, saw them as a patient. But you just stuck your head in the door and said, "Hi, how are you? Um, we agree on what we ought to be doing, and that's it." Won't you feel better if that happened? If you
I
were
think, yeah, and that's easily said in this setting, but in the throes of a busy department, I just don't see that happening regularly. I
no,
think
I don't.
I think
I
I think there need to be guardrails up where you need to go to the bedside in certain cases, and in high risk cases and all. There are times that the PRNP will come up and say, "Look, this patient has." Fractured wrist. I talked to orthopedics,
mhm.
it's non-displaced. We're going to follow it up. We're putting a splint on it and, away they go. Or appendicitis, going to the operating room. They've done the CT, it's been diagnosed. Does the family need anything? That sort of thing. And I won't necessarily go to the bedside, but hearing about that, seeing the chart, recognizing that there aren't any problems missing is really important. And we did a study non-published on the non tangible influence of having an emergency physician in the department. Those things that don't make it into the chart. When you oversee an ECG, you look at an X-ray with the PA or NP. Those things often don't make it into the chart. But those are the non-tangible input, the things that you do that impact that care. Even if you don't go to the room, you can still have that impact just in that discussion briefly.
Well, I acknowledge that what I'm asking for is the ideal. Some
Right.
people would say that's not the ideal. That is not the ideal. And just as you said, somebody with a broken wrist, we got the whole thing taken care of, no problem. But I think it would be great to stick your head in the door and say, I'm Dr. So and so. This thing looks like it's great. He's handled it fine. We're gonna send you, and that's
Mhm.
just just a little, just a
Yeah.
little, because you need to be freed up from as much of the busy work of the department as possible. Nobody else can write a history and physical
Right.
except you and the PARNP. if you were in there together with the patient and you started out and it's a congestive heart failure patient, somebody has to do a history and physical on that person. Um, a scribe does not have the authority to do that.
Right.
A PA or NP does, or a doctor does. So this is an intellectual process where you're seeking out, and what's the precipitating factors for this condition, those kinds of things, which are more intellectual than I stepped on a nail. And so that's what you're doing. And so you just can't say, well, you're just making me a scribe out of this. They don't have the authority to do what you're doing at all.
Yeah.
So I, I am. I like my idea. I don't.
Yeah.
One of my concerns is that it's just getting a little too easy to feel comfortable, and that patients, as you talk about guardrails, they don't exist necessarily. And so I do think if you're going to have not everybody seen by emergency department, which a physician, which is probably the reality of the world, well, then as a minimum, you have to set up guardrails. And I think there maybe need to be guardrails based on your experience and what you've had. A new person is going to need very very large guardrails. You've been working 10 years, well, your guardrails are going to be wider in terms
Yeah.
of what you're able to do.
Right. Well, and speaking of that as well, where those guardrails really don't exist is in the rural setting, and that's an area that I have a big interest in having worked rural for most of my career, at least part time, and being part of the rural task force there, or and the rural section for ASEP. There really aren't guardrails there because there are no real significant conditions of for onboarding standards in the conditions of participation for these critical access hospitals. You need to have ACLS, ATLS, and PALS, and that makes you an emergency provider, whether you're a physician or PA or NP. And so part of this series is advocating to, looking to individuals and organizations that are looking to raise that bar and provide a level of training for these providers that are going to work there that'll help them to be more successful and provide safer patient care and be more comfortable in their care. And unfortunately, there aren't a lot of high volume facilities for Ps and NPs to go to anymore because those are saturated in the emergency department, just like they are for physicians. And some of the only positions available are in rural, and you really shouldn't go work rural until you've got your legs under you, having, thousands of hours really in a high volume facility working alongside emergency medicine trained physicians.
Well, I think this like my theory or postulate that everybody should at least have the doctor say hi, how are you, kind of thing.
Mm-hmm.
Yours is similar because it's like that's an ideal situation, and it's going to be really tough to achieve that. So in the meantime, there got to be some alternatives, like I don't know what you call it now. What used to be a Vera,
Oh,
you know,
Avel,
Avel.
telehealth system. Yes.
Yeah, that system. I've talked about that before. I think that was very, very, very cool. And
Mm-hmm.
you've told me a lot about how it was funded and
Yeah.
which I didn't know.
Yeah.
But they're involved in hundreds of hospitals, plus they do a bunch of other things. But um, I think that's kind of a great idea. But it's certainly there are. I think there are like something like 1,340 critical access hospitals, and the number is getting smaller every day. The number of critical access hospitals is in that neighborhood, and I know some of them are solely staffed by PAs. I know a
Yeah.
place where it's 5 PAs, and if it's not those 5 PAs, it's going to be nobody.
Right.
So it's kind of like, you. It's not a perfect world. You have to make do with what you have. So these people are very good. This guy comes to our course in Key West every year. If it's not there, he's at one of the others.
Yeah.
He's really passionate about his desire to keep up, and so so it's kind of like I can live with that. It's these guys are certainly better than nobody.
Right.
And if they could get, there's no physician on site, and if they could get some support through some kind of telehealth system, that would be, that was be better than what they have. But I think that you have to kind of acknowledge that in the rural areas, they're going to be tough to staff. We've also talked about this idea of, big systems where physicians rotate out to hospitals that are not tiny hospitals, but, kind of, I think you mentioned something around 5,000 or something like that. So 5,000 is like, 15 a
Half
day.
patient an hour. Yeah.
Yeah.
Yeah, about 4,500. That's what we've defined in the rural section as frontier critical access hospital, and CMS defines a frontier critical access hospital. And then there's extreme frontier that are less than 2,500 volume per year, and I've seen some of those as well. I mean, I drove home from Arizona a couple of years ago and actually stopped at one in along the way in Wyoming. That's just one thing I'll do is, cold call and talk to a provider there and just say, hey, who staffs this, and what's it like, and what's your training? And a lot of times they're paramedics who have become PAs or NPs, who are very good with resuscitation and with that sense of being able to provide independent care, but they need to know their limitations as well, and they're essentially triaging and then getting sick people onto a different facility, and then they do some minor procedural things, but there's very little support for them. But they're in a spot, there's one place that they saw less than 500 patients a year in Wyoming. I mean, you'll never afford to have a physician there, and a physician would have no interest to go there if you're emergency medicine trained. And so what do you do to fill that void? Do you close that and then not have a hospital within 20 or 30 miles, or do you have
Probably.
staff with? Yeah.
Probably.
Well, and it depends. Some are even bigger barriers than that on other sides of mountains in the in the Rockies, that sort of thing. What kind of distance is acceptable between emergency departments?
Well, sometimes it's not just the distance, but it's the weather.
True.
Where you live, as an example, or Alaska,
Yeah,
where you can't fly, you can't drive, and you're stuck with them.
yeah.
Although it's kind of interesting, I think that paramedics learn all of this airway kind of thing because it's essential that they be able to manage an airway. Not necessarily they have to intubate, but just other kinds of airways that they can learn to use. Paramedics can't do anything in the hospital in California. You cannot cross that threshold, even though you can intubate in the rain on the street.
Yeah.
You're not allowed to do anything in the hospital. Now, who came up with that idea, I wonder?
I let a paramedic intubate back in 1995, I think, in the ER before I knew those rules. He was doing a shift. We were just starting to have paramedics work in the ER to help out as techs and help the nurses out. And he thought, yeah, I'll do that. And they were paying more in the hospital than being a paramedic.
Yes.
Missed some of that autonomy, missed doing airway. I said, oh, here, you can do one with me. And, I'm right there with him. I let him do the intubation. And oh man, do we hear about it, because he's working under the nurses. The RNs are like, well, I don't get to do that. why does a tech get to do an intubation and I can't? Well, it's because he does it in the field, but so, do you find that you're seeing in your boot camp more PAs and NPs than physicians? Did that transition, or has it always been about the same ratio?
Oh no, it's by far more PAs and NPs. We've had about 11,000 physicians go through. In the rural areas, we have physicians who are family physicians who are covering the ER, and we've had surgeons covering the ER, and actually surgeons who go from here to there covering various emergency departments. So we've had lots and lots of non-EM boarded physicians attend because I think in the rural areas, and I think honestly it's great for them to want to get better at emergency medicine. I think
Sure.
it's also kind of scary for them to be out there too, in
Mhm.
terms of, well, a surgeon may be great if you have appendicitis or something like that, but it's not so great if you necessarily have an MI or a subtle MI, like posterior MI or something like that.
Yeah.
Um,
Yeah.
but then again, it may be better than nobody.
Right. 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 No.
And
Well.
I appreciate their willingness to try.
Right. Well, and to collaborate, and telehealth should really be there for anyone that really needs that. And Avell makes themselves available to these physicians as well. When you are shorthanded and you need people to help arrange your transport to another facility, that's actually what telehealth does as well. So
I'm just
it, it
blown
should be
away
made
with
more broadly available. Yeah.
the service that they provide is just pretty extraordinary in terms of backing you up. But you had mentioned that a lot of I don't know if do our listeners know what that service provides in terms of you probably have told
Yeah,
people in the past.
we did a podcast with Tyler Price, a physician who's their medical director at Avell, and talked about their process and their agreements with various hospitals, and then how they assist in critical cases and other consults.
My concern is they have it's the Lexus of it used to be the Cadillac, but it's not. It's the Lexus of backup systems,
Yeah,
because it's not only the physicians, but they have all of these cameras and microphones, and you push the red button on the wall and everything gets activated. And unfortunately, they may be at 200-300 hospitals, but there's of the 1,300 critical access, they've got a long way to go.
yeah,
If they were to make any penetration into the field, and it would be great. But I think that there's this barrier to access, because it's not only the physician sitting at their computers helping out, but they have all of the startup costs, which you have to have a bake sale for to get the $20,000 or $30,000 you need to have these cameras installed
yeah.
and these processes in place. So I think that it probably there's this barrier to entry that would be great if it could be overcome, so that systems like that could just kind of be proliferated,
Yeah. I was
because nobody's going to say that's a bad idea. So
yeah,
what's the resistance to this idea? Well, it has to be money,
right.
or maybe they have limited capacity. I don't think so, since they're now on the stock exchange.
Yeah. Well, I was on a committee to help write the conditions of participation for CMS for conversion of critical access hospitals to these rural emergency hospitals, the
Hmm.
standalone ERs. And when we started talking about ideals, just like you're referencing, we started making conditions that were more stringent than they are for the current critical access hospitals. And we couldn't touch those. That wasn't part of our ask. Was only to look at the rural emergency hospitals. What should those conditions be? But if you made those conditions too stringent, then no one would make the conversion. They'd just stay a critical access hospital, and so we had to temper them or just give recommendations. So there's a ripple effect in any kind of change you want to make, and really what it takes is something sweeping from Center for Medicare and Medicaid to look at this and say, look, we do have a problem. We want to get parity with our urban counterparts in the ED. How do we get there, or how do we incrementally get there? And I think we're starting to move that needle and getting organizations to take a look at this issue, because it's super important. So
Yeah, and I think that the stimulus is not going to come from private enterprise. This is going to come from the feds, because it's going to be probably a money losing endeavor.
yeah,
But if you feel an obligation to provide medical care to the rural areas, you just have to kind of step up to the plate. Unfortunately, it seems there's nobody has any money.
Right.
We got all these wars and all there's just no money. And
Right. Well,
then some
we've got a federal debt that's
umpteen trillion dollar
staggering. Yeah, right,
debt kind of
exactly.
thing.
Yeah,
And so there's no money for anything. And I don't think anybody would say this is a bad idea.
right.
It's just like, well, where's it going to come from?
But
And some of the
theoretically, if you've got a physician staffing 7 emergency departments at one time, and that's really the Mayo model, and we looked at that as a model of best practice when in looking at through the rural task force we did through ASAP. There will be one doc that is responsible for 7 hospitals where you have PAs and NPs working, and they will the doc will see the track boards at each of those places and can set up their own guardrails so they can see vital signs of patients that are coming in, and that's all they're doing. They aren't working on clinically on a shift. They're watching those various ERs. So that's a highly efficient way to do that
oh,
and
I bet.
that service. So there are innovative ways to do this. And once you've got some of that infrastructure in place, it's just a matter of leveraging that and having some of those experienced physicians spend time at tele-EM and help provide that service, and then have a good relationship with those PAs and NPs that are out at those facilities, where you can't
Yeah, I
afford to
think
get the docs there.
I think that that's true, but we did need to find a way to get it paid for, because there's nobody who's going to say no.
Yeah.
So the idea is basically to create the infrastructure, I think. And I think we should just do a gas tax for your state, so you could expand it. And we don't want to need it. We don't, want to have a new gas tax in California. We'll have to think of some other tax.
Sure.
I don't think there's any taxes left that we don't have in California. But I do think, honestly, the rural states maybe the idea of this is a state obligation, because the feds aren't going to pay for this. They might throw in a little bit here and there through Medicare, but they're not going to write for the infrastructure for these hospitals or these other facilities. So it's kind of like, well, maybe the state ought to take it on state by state. That would be better than nothing.
Yeah. But on things that we can control, like providing education and that sort of thing, these are hopefully resources that our PAs and NPs and non-EM trained physicians can take advantage of and do these courses, do procedural courses, spend time hopefully at a higher volume facility, and if they are working there, and then spend some time rural. I've been doing that for a number of years. I'll work in a higher volume level 1 and level 2 trauma center, but I still have had my foot in the rural setting throughout my career, and now it's about half time that I've been doing for the past number of years. So, and it's very rewarding and it's very insightful as well. So, but that people appreciate it, the nurses appreciate it when you're out there. They go, "Oh, you're the doc from the trauma center." They like that.
Well, we've talked about it before with this idea of if you have a big enough pool of physicians that you can rotate them out for a period of time out to the rural areas, because I think that there is a certain sense of satisfaction that you get out there when you're alone. You're the only one there. You're not necessarily overwhelmed by patients, but you get paid what somebody brings in a chicken to pay you, kind of thing. But I really appreciate that. I was in the Indian Health Service for 2 years, and the first year I was on a reservation as the only doctor. With the closest hospital was 50 miles, and so I do have an appreciation for rural healthcare, and I do think that I have an appreciation for the people who are willing to do it, and I think there's also a level of satisfaction that you don't get when you're working in a community emergency department, because you're unlikely to see the patient again. But when you're working in a community place, you often see these patients and you get to know them, and it's totally different. It's almost like a private practice, but it isn't.
Yeah. 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 Well, and the nurses recognize, when they've got someone in, like the other day, I got asked, or someone had a large pleural effusion, had cancer, short of breath, and they go, "Oh, you do thoracentesis?" I'm like, "Yeah, we can do that, and help this guy out." So
Well, one of the
we do
things
those procedures.
I don't I can't remember the name of the new Avera. Tell
Avel,
me that
Avel,
Avel.
yeah,
Avel. Um, it, they basically make the case that if you have physician capabilities like their backup, that more people will stay at the community
right,
hospitals, and that will pay for the whole thing all over. Because instead of sending, this bump on the head for a CAT scan down, you can say, no, you don't need to do that. We'll just observe them overnight in the hospital, kind of thing.
right.
And because it doesn't have any of the PCARN criteria for a CAT scan, and I feel comfortable just kind of watching this kid. We won't be calling in a helicopter to go down
Right.
to. And so that was the case. It was a financial case that they were making, that you can keep these people here, but you can't make that case if you're going to turn them into freestanding ERs.
True. If they need to get admitted, they're going to get a descent. But whether they go by helicopter or by ground, could make a huge difference as well financially, and helping make that decision can be
Yeah, I
important.
think that they were, thinking about things like a cellulitis could be staying at your community
Sure.
hospital, you know, things that were
Well,
not necessarily dangerous.
and there's
You know,
certain observation criteria. It was really Greg Henry's brainchild, wasn't it? These rural emergency hospitals, and isn't that what he said? Oh, all you need is an ER. That's what those people want in those communities. I've never seen him been given credit for the rural emergency hospital, but wasn't that his?
honestly, I don't know. I talked to him yesterday, but I know most of his ideas, um, the good ones and the bad ones.
Well, I
But
remember him being on a rant one time, as he, commonly does. But he was like, "Oh, people, all they want in a rural setting is an ER, a good ER, and you got to be trained out there." And he was always advocating for that. And then when he was president of ASAP, he really voiced that even more. So it seemed like, that must have gotten seated somewhere, and then out of nowhere, it ended up in an omnibus bill, and all of a sudden, hey, we're going to have early emergency hospitals. And
no,
it got everybody by surprise.
I never knew that. I never knew that.
Yeah, well, I have to ask Greg next time you talk to him, because I've
Oh,
never heard anyone else say.
he'll claim ownership of any idea you pass by him. Yeah, oh yeah, I thought of that. Yeah,
That was me. Well, I
yeah.
really don't know of anyone else that came up with that except him and had talked about it. So anyway. So, well, hey, thanks for hopping on today and talking about onboarding and being a visionary and recognizing that need as well. The boot camp was the first of its kind in really revealing the need for that, and providing it all in one for people that needed to get set to start to work in the emergency department. And it's good to know that those ambitious PAs and NPs and non-EM trained physicians recognize that need as well, and clammed on it.
Yeah, it's really nice to see that people want to do a better job, or
Yeah,
and they're training of a PA or an NP or pretty much any other kind of physician doesn't really, without additional training, it can be very hairy working in the emergency department, because
yeah,
anything can come into the ER in this little place. You can still have a heart attack out there. You're allowed to have a heart attack out there. You got your hand caught in some machine, or this or that or the other thing, or you got uh, any variety of things can just come into a rural ER just as much as they can come into the bigger ERs.
yeah, yeah, yeah. No, for sure. And so there isn't any cookie cutter recipe right now, but it does require, I think, an extensive onboarding process. And we tried to lay out the framework for that in the Rural Task Force. And we've talked about this in other podcasts about the 5 pillars of things to do. And we've talked about that as well. But it certainly starts with good foundational training, and then from there, getting your procedural skills and clinical skills and working in a high volume facility, but really having that telemedicine support is critical as well. And we expand that to have ED physician directorship at all these emergency departments, because you could be a medical director at many different emergency departments as well and oversee at least the activities, even if you don't work there.
Oh yeah, I definitely believe that.
Yeah. So, well, good. Well, hey, thanks for meeting today, Rick, and catching up and talking about onboarding emergency medicine. I think our viewers will find this very helpful and informative, and hopefully we're going to move that needle further on improving the onboarding standard for all emergency departments, but particularly our focus, or part of the focus, is in rural, good part of it.
Well, good luck on your efforts. You've been at this for a good while.
Yeah.
Well,
But
then
I think
again,
it's
we all
working.
have.
True. But I think we are seeing some movement, and it's very encouraging what ASAP is doing and all in this avenue, and collaborating with AAFP and all in having oversight and improved care in rural as well.
Well, did we find the solution for this thing? I mean, anybody write down the answer,
Yeah.
that we came up with,
I think we touched on a few, but we'll get there.
Yeah, I'm suggesting a new gas tax in your state to fund all the other rural hospitals that don't have the opportunities that some have from Mayo.
It may require some additional money, but I think utilizing a lot of the money that's already in the system and reallocating it, and redesignating and making it more efficient is part of this as well. The turnover that we have in PAs and NPs going to a lot of these rural places, they burn out pretty quick when they have a bad outcome and when they go and aren't onboarded well. And that alone can cost $250,000, $300,000 to replace them. So if we're going to keep turning them over, that's not good for the patients. It's not good for the provider. It's not good financially. So reworking this entire process and having something that's workable and sustainable long term is really the answer, and that's what we're trying to work toward and advocate for a more consistent and really improved onboarding process. So
thanks so much for inviting me.
Yeah, you
I
bet.
enjoyed talking with you again.